Hi, thanks, Jen, and thank you everyone for attending today. I really appreciate your time and your attendance, and I'm very excited, of course, to speak about something that is near and dear to my heart, which is the shoulder, the rotator cuff specifically. And I have a lot of questions from patients in the office about the rotator cuff and really what is it, and what is it all about, and why is it a problem? So I thought, this may be a good opportunity to share with folks my take on the rotator cuff, what the science is behind the rotator cuff, the function, and so on, and answer some of those questions that a lot of you may have. Okay, so about me. First, my name again is Ed Armbruster. I'm an orthopedic surgeon. I have specialty training in hand and upper extremity, and I went to undergraduate at the University of Michigan, and then I went to graduate school at Boston University School of Medicine. I went to medical school at the Philadelphia College of Osteopathic Medicine, and did a residency training in orthopedics at Rowan University in South Jersey. I finished a hand and upper extremity surgery fellowship program at Rutgers University in Newark. And I've been in private practice since, which is over 10 years. I'm originally from New Jersey, the Atlantic City area, and currently I live in Pennsylvania, in Bucks County with my wife and 3 kids, 2 of whom are in college. I have a special interest, of course, in hand and upper extremity. Early in my orthopedic career, I became enamored with the upper extremity because of the complexity of the anatomy and the number of different skills that a surgeon would need to be able to effectively care for conditions of the upper extremity. So it incorporates not only orthopedic skills with fixing bones and tendons and so forth, but also part of my fellowship training was with microvascular and repairing arteries and nerves and what have you, taking care of burns and whatnot. If you can imagine any kind of an injury that would occur to the upper extremity, that's something that I've trained with. So I'm very, very happy to be here today and to share some of my passion with you. So what is the rotator cuff and what does it do? Well, the shoulder itself is an amazing joint. I guess I'm a big fan, having dedicated the better part of my life to understanding it, to treating it, repairing it, and sometimes replacing it. But what is it about the shoulder joint and the rotator cuff specifically that's just so lovable, I guess I would say? Well, where should I start? The shoulder joint provides the greatest range of motion from any joint in the human body. Its range of motion has been described as full in all planes, which means you can really place your hand and arm in just about any position. What that means also is that the freedom of movement is due to the brilliant design of the shoulder itself. So the shoulder at its core, the bony parts, I should say at least, is a ball and a socket joint, as we can see here. Here's a ball, and there's the socket for lack of a better description, but I'll explain the method to my madness here in a moment. These photos, of course, are an oversimplification, but you have to start really somewhere. The round ball on the flat plate allows for the shoulder to twist, to rotate, turn, slide, and glide and roll. But how exactly does that happen? What are the magical forces that are responsible for these kinds of motions? How is it that the shoulder functions to position the hand in space? That's what it really does. Our shoulder helps to put our hand in different places so that we can interact with our environment. Throwing a pitch, scratching your back, or just raising your hand. They're pretty cool tricks, but the shoulder exists to position the hand in space and allows us to interact with our surroundings and our environment. It represents how we interact with the physical world that surrounds us, which again, I think is pretty cool. As an upper extremity doctor, I like to say that the whole body, in fact, exists perhaps to position the hand in space, your legs, your spine, your arms, your hand, so that we can interact, we can move around our environment, we can affect the environment, care for ourselves and care for others. You see what I mean now by the shoulder really being an amazing joint and tremendously important? So if we take a look, and as I mentioned, the shoulder is a ball and socket joint, as we can see here. Now, as you can see the image on the left, the ball is the humeral head, or the top of the humerus bone, which connects the shoulder to the elbow. The socket is the glenoid. Or basically the plate upon which the ball both rests and moves. The bony architecture, as you can see, provides unlimited motion for the ball. On the right, you can see the orange ball on the plate. The ball is free to roll and spin and twist and turn in response to any force that's placed upon it. The image on the left, while it's an artist's representation, has a deep socket, as you can see. The ball literally fits into the socket. In reality, the ball and socket depicted in the artist's rendering is closer to a hip than it would be to a shoulder. But why is that? Well, because the socket of the shoulder is more of a plate or a flat structure than a true socket or a concave, a curved type of a socket. The image on the left is closer to the hip. How do they differ though? Well, there are many differences and in fact a few similarities. Although both joints are ball and socket joints, the hip is more constrained, meaning that the socket almost wraps around the ball as you can see in the image on the left. This makes the joint very stable, and in fact, it will limit the motion. Now, you can imagine your hips don't move as much as your shoulders do. Think about it. Have you heard of somebody ever dislocating their hip? Well, their native God-given hip? It does happen, but it's not very common. We've heard, of course, more commonly of people dislocating a total hip replacement. But think about the times that you've heard perhaps of somebody dislocating their shoulder. It's much more common. And why is this true? It's because the ball in the socket of the hip is more constrained, more stable, and therefore provides less motion than the ball and socket joint of the shoulder. The shoulder, on the other hand, is less constrained. It's less stable, but it also provides much greater motion. Recall what I said about the shoulder range of motion? It's virtually unlimited and very well suited for its function of placing the hand in space. Now here I have a pretty simple representation that I use to teach folks about the shoulder. So what is this? Well, some tape on a ball holding it in place. Well, yeah, that's exactly what I've done here. I've placed 2 lengths or 4 straps of tape on the orange ball to hold it in place. It's pretty stable now, you would agree. Really, ball can't go anywhere. While it's an oversimplification, the tape represents the rotator cuff tendons, as I will explain. In this case, the tape holds the ball in position so it cannot move. As it pertains to the shoulder, however, the tape represents the tendons, which are extensions of the muscles, or where the muscles attach to the bones, in order to move them. By the way, sometimes people confuse tendons with ligaments, so I'll explain that a bit. What's the difference? Tendons connect muscles to bones in order to move them. The muscle contracts and it pulls on the tendon, as I'll show in an image coming up here, which is then attached to the bone. The bone then moves. Ligaments, however, they connect bones to each other. Has anyone ever sprained their ankle? The sprain is a tear in the ligament that attaches the ankle bones together. The tear can be mild or severe, or as in a mild or severe sprain, in fact. When a ligament is injured, we call it a sprain. When a tendon is injured, we call it a strain with a T. Remember, strain has a T in it, reminding you that it's in fact the tendon itself that's injured. Well, back to our ball and socket, and now the rotator cuff. The tendons, or the pieces of tape, hold the ball in position. You can imagine that if I pull one piece of tape, the tendon will move in that direction. Another or opposite piece of tape, well, the ball will then move in the opposite direction. That sounds pretty cool, huh? What would happen if I cut one of the strips of tape, as we see in this image on the top left? How could this happen? Well, it's almost as if the tendon now has become torn, one of the 4. Well, regarding the shoulder, it could occur from an injury, such as a series of injuries or simply from a tendon wearing out over time, which is sometimes what we call tendinosis. So there you can see the 2 long strips, but the 4 segments, one is torn. And you might agree that that ball is free to move just a little bit more than if it had all 4 pieces intact. In the next image, we've cut 2 pieces of tape. The second tear makes the ball even more mobile or unstable. But what about 3, of course? Even more unstable, pretty significant instability. And 4? Well, the entire ball can now roll around the plate. And now we have the greatest instability, the greatest motion. Whereas on one hand, that may seem to be desirable, we really don't have those tendons now that can actually help to control. In reality, rotator cuff tears, or the full thickness ones, they weaken the shoulder and they allow it to move in ways that can end up actually hurting the shoulder. The ball can slop around the plate almost like a loose gear in a gearbox. The loose ball then wears improperly. It causes the other tendons to be stressed if there are other tendons that are intact, and they are stressed inappropriately and places them then at risk for tearing themselves. The loose ball can even destroy the joint itself by moving all around in a very loose or sloppy fashion. And sometimes we'll refer to that as what's called a rotator cuff arthropathy. So here I wanted to show the rotator cuff and where it's located in our own human bodies. You can see on the left, the back view. So if you're looking at a person from behind, the shoulder blade you can see, and on the leftmost image is the supraspinatus tendon. On the middle image is the teres minor, the infraspinatus, and the subscapularis. Now I went through that rather quickly, but I'm going to back up and bring this down to make it a little bit more understandable. Again, on the left, we're looking at the shoulder from the back. I add this rotator cuff image to show you where the rotator cuff exists in its natural habitat, so to speak. The four muscles of the rotator cuff are the supraspinatus on the left, the infraspinatus, which I skipped one between teres minor, then the teres minor, then the subscapularis, which you can see there from the front. There's a mnemonic that we sometimes use in medical school. It's called SITS, S-I-T-S, supraspinatus, infraspinatus, teres minor, subscapularis. That helps us to remember the four tendons. How did they get their names? Well, it's actually pretty simple. If you look at this close-up image of the rotator cuff, you'll see that the muscles are attached, then the tendons reach out and they're actually placed upon the humeral head or the ball and socket. Now, the shoulder blade itself is called the scapula. In fact, the plate that we've been discussing that has the orange ball on top, that's part of the scapula too. It's called the glenoid. But before we get too complicated with names, how do the names derive? Where do we get them from? Well, the shoulder blade itself has a spine, and you can see the spine here. It's that tan line separating the top muscle, the supraspinatus, from the bottom muscle, the infraspinatus. On the left image, you can see that horizontal tan line. And you should be able to feel your own shoulder blade on the top. If you reach over the top of your shoulder, you can feel that ridge of bone. On top of the spine, or supra, is where the supraspinatus lives. Spinatus, the muscle supra above the spine. That muscle serves to elevate the shoulder joint up and out to the side, up in this direction. The infraspinatus is below the spine. And on the front image on the right, you can see the subscapularis as well. But if we go back to the infraspinatus, that's below the spine, and that externally rotates the shoulder, rotates it out to the side. The subscapularis we could see from the front view because that's literally beneath the scapula, subscapularis, basically fans out the entire portion of the scapula, and that helps us with elevation of the arm and internal rotation. And then finally, the teres minor muscle, there's a teres major and a teres minor. Teres in Latin means rounded. Major is a larger muscle of the two muscle group, and minor is the smaller. And teres contributes, but quite honestly, in a clinical sense, teres doesn't do very much for us, or I should say teres isn't very often involved in pathologic conditions of the shoulder, such as in a rotator cuff tear. So what does it do? What exactly does a rotator cuff do? Well, it compresses that ball on the socket. It compresses the ball on the plate, so to speak, just like the four pieces of tape would. It stabilizes the humeral head on the glenoid. And of course, it assists with glenohumeral motion. Now, there are some other muscles that assist with glenohumeral motion as well, but the rotator cuff is critically important to maintaining the relationship between the ball and the socket. Well, what happens if the shoulder doesn't do what it's supposed to do? What do we experience? Well, oftentimes folks will come into the office with a complaint of limited motion. They'll have weakness. They'll have pain. Quite simply, they have difficulties with activities of daily life. That's usually when folks will present and come into the office and seek care. So here's your sign. If you experience pain here at the side of your shoulder, it could be a rotator cuff tear. The rotator cuff has above it what's called a bursa, which is a lubricating type of a tissue. It lubricates the tissues so that they can slide between each other without causing too much friction. The bursa extends out laterally over the edge of the shoulder in this direction. And it can become inflamed anywhere, even right above the rotator cuff. And when this happens, the pain can radiate out to the side of the shoulder where this person's hand is. When we give injections into the shoulder for bursitis or for a rotator cuff tear, we usually provide them in the back of the shoulder, kind of back in this area here. We do this because it's a safe place to inject. There aren't any critical structures in that area which could be damaged with a needle, such as a nerve or an artery. When you inject into that bursa, the medicine will spread all through the shoulder, so it catches the front, the back, the outside, and the inside. And so that's how you get the benefit from the injection. It helps to reduce the inflammation. So what can you do if the shoulder or the rotator cuff isn't working and it's not doing what it's supposed to? Well, you have several options. The first would be you can live with the condition. You'll see that surgery is up on the list there, but of course it's at the end of the line, which is what it should be. Surgery is a tool in the toolbox, but it's not typically the first tool that we reach for. Again, we start with non-invasive means of treatment. First, if you can live with it. A rotator cuff tear won't kill you. If you can get by with one, you can certainly live with it. In fact, many people do live their lives with small partial thickness or even full thickness tears. This is a very good option for a person with a small tear or a person who may not be quite as active. Activity modification can also be very useful. What do you do if you can't reach a box of cereal in the cupboard? Well, you can move it to the counter. What about tennis? Well, you may play pickleball. There are alternative activities that will still allow someone to be active, but just in a different way. Different ways to skin the cat, as they say. What about physical therapy? That's a great idea. PT makes whatever you have better. It strengthens the torn tendon, or if it's partially torn, and other tendons which are not torn. In short, if we can make your torn tendon a little bit better and make the other tendons around it just a little bit stronger, we have a victory. We've improved the function of your shoulder and compensated for any kind of a decrease that you may have as a result of the injury. You might just be able to continue with your tennis after all. And how about medication? There are a number of transdermal creams like Voltaren gel and such, and non-narcotic medications such as ibuprofen, of course, acetaminophen, that can help with the pain when it happens. Personally, I don't recommend that anybody use medications for an extended period of time because of the potential side effects that can occur. But in the short term, when the weather's bad or maybe when you've overdone it, a Motrin or a Tylenol can help in a pinch. Now, what about injections? I hear patients say they're afraid of injections because they just mask the pain, or maybe they've heard that steroids can damage your tendons or joints. Well, these statements are partly true. If a person has bursitis alone, the injection can help to break the cycle of inflammation and effectively cure the condition. What about the case of a rotator cuff tear? The injection will relieve the inflammation associated with the tear for a period of time, but that period of time could be days or weeks, months, or maybe in fact even years. In fact, the steroid injection can seem to cure the tear, but does it really? Well, no, not exactly. Nothing can fix a torn rotator cuff tendon except for surgery, but not every tear requires surgery. In fact, the majority of rotator cuff tears do not. I usually suggest a steroid injection if everything else has failed, but the symptoms unfortunately would persist. I also don't recommend too many injections. It is safe for a person to receive an injection in a given area once every 3 months. So if you have an injection in your shoulder, you can have an injection in your knee within a couple of weeks or days. That's certainly fine. But to receive another injection in the shoulder or another injection in the knee, you have to space that out by 3 months. That allows the body to recuperate to some degree, and we can minimize the adverse effects of the injection. More often than that can lead to damage to the tissues on the inside. So guess what? That's exactly why I don't offer these injections in the same area inside of every 3 months. We just simply won't allow it. Finally, we have surgery. This is the final tool at the bottom of the box. Surgery can be useful in cases where a person has tried and failed everything else. We also turn to surgery when the tendon tear is so severe that non-operative care would not be helpful. In fact, it would be fruitless, wouldn't help at all. In these cases, surgery can be very useful and is frequently a cure for the tear itself. So what do I do? What to do? How do you decide which treatment option is best for you and where you live with your shoulder now? Well, I wouldn't suggest you ask Dr. Google or Professor Facebook. When it matters most, we consult an expert. call me. I'll work with you to identify the problem and we'll develop a treatment plan together. These treatment plans are customized to a person's needs. I see athletes, pitchers, quarterbacks, linemen, tennis players, and the like. I also see weekend warriors, true soldiers and sailors, tradespeople, and everyone in between. I see young folks and I see older folks. In short, anyone with a shoulder that's giving them trouble, I'm happy to see and care for. Together, we get to the bottom of the matter and we formulate a customized plan to get you to where you need to be. Everyone's needs are different, and I respect that. Patients come to me at various stages of their shoulder journey. They might have had pain for a week or two, or maybe even a year or two. Some have tried everything, even surgery. Others haven't tried anything just yet. It's okay. My favorite part of medicine, besides education, is working with people to get them better. It's a true team approach. So before I close, I want to share a couple of other items that people often ask about as it pertains to the shoulder and the rotator cuff. Of course, I'll be happy to answer any questions that you may have at the conclusion of the presentation. First question that I'm frequently asked is, what are the different kinds of rotator cuff tears? I'm glad that you asked. A partial thickness tear is, as it sounds, when the tendon is incompletely torn. We refer to these tears as either low grade or high grade. You could see in the image on the left, part of that tendon where the jagged line is torn. It's not attached to the bone. As you move further in the same image, you can see a portion of it is attached to the bone. Low grade tears, what we refer to as low grade, is when the tendon is torn less than 50% of the thickness of the tendon. These typically do not require repair. A high grade tear, however, is when the tendon is torn greater than 50%, but not 100%. These do usually require repair. And sometimes partial thickness tears will progress over time to become a full thickness tear or a high grade partial thickness tear. Full thickness tears, as you can see on the right, are when the tendon is completely torn. And in fact, sometimes it retracts because that tendon and muscle, they're under tension. And if we release the tension by cutting or tearing the tendon, the muscle can then retract and pull the ends apart. That's to say the tendon remains attached to the muscle, and then the other portion of the tendon remains attached to the bone, and there's a gap that develops in between. Sometimes the tendon may actually simply pull off of the bone itself. Surgery in these cases repairs the tendon back to the bone where they can effectively grow together and heal. So the way that we repair these is by either putting tunnels in the bone or putting an anchor into the bone, typically made of plastic or a bioabsorbable material which will dissolve with time. And that anchor has sutures. We pass the sutures through the tendon and we suture the tendon back down to the bone, and allowing the tendon and the bone to heal back together. That usually happens between 6 and 8 weeks. After that point, the sutures or the stitches will remain inside. You won't know that they're there, but they've really served their function at that point. Another question I'm often asked is, how do we diagnose a rotator cuff tear? Oftentimes, a person's story will give us clues necessary to diagnose a rotator cuff tear itself. How did the person get hurt? Was it skiing after a fall? Was it with playing tennis or just increasing pain over time? As a surgeon mentor once told me, if you listen to the patient, they will tell you what's wrong. And so I always start with listening. A good physical examination can also be very, very helpful. An examination is geared to isolate the 4 tendons of the rotator cuff and to see which one or several may be problematic. Is it the supraspinatus, the infraspinatus, or the subscapularis? Well, you guessed it, there's a test for those. Our physical exam will help us to narrow the possibilities of what could be wrong with the shoulder. MRIs can detect about 98% of rotator cuff tears. Now, MRIs are only as good as the quality of the scanner or the magnet. And by the way, an MRI is not radiation. A CAT scan or an X-ray would be radiation. An MRI obtains the image by use of a magnet. That's a topic for another day. But the MRI is only as good as the magnet or the scanner itself, not to mention the human who's reading the image on the other end. That said, there aren't many rotator cuff tears that get past the MRI, but I have in my career seen a handful, which leads us to the last option, surgery. Surgery, arthroscopic surgery specifically, is the gold standard for diagnosing a rotator cuff tear. With tears, if you can't see it with your eyes and it wasn't on the MRI, then it's not there. Sometimes, though, the MRI is normal, but a person still has pain with no obvious cause. In these cases, we consider other sources, such as a neck, a pinched nerve in the neck, or maybe an occult rotator cuff tear that we haven't been able to identify with an MRI. The arthroscope, or the surgical camera, can be immensely helpful in these cases. Not only can the tear be identified, but it can also be repaired at the same time if need be. So what have we learned? Is it that the shoulder is a ball and plate? No, but the ball and plate example helps us to understand this wonderfully complex yet amazing joint. The rotator cuff plays an essential role in the proper function of our shoulders. Without it, or when it fails, we can experience pain and lack of function. I've dedicated my life's work to the human hand and upper extremity, not to mention the shoulder. It is a worthwhile mystery that we're still learning about, and I'd be delighted to help anyone on their road to recovery. I wish to thank you all very much for your time and attention, and I'll now be very happy to take any questions that you may have. So the first question is regarding the talk being available after the live session, and yes, it will in fact be available. You can go to our website for additional details, and Jen can give some additional information in that regard.
Yes, I'll just hop in real quick. So this video will be uploaded to our YouTube channel. So you will be able to view it on our YouTube channel at any point once it's uploaded, but it does take a few days to upload it. Anyone who was registered for this webinar will also receive a link to the recorded version in 2 to 3 days.
Great, thank you. Another question, are rotator cuff tears common in young kids? Is the treatment plan any different for kids? Great question. So rotator cuff tears are not as common in kids. As we get older, the tendons of the body in general, and specifically those of the rotator cuff of the shoulder, they're not quite as strong as they had been. Kids, especially kids that are still growing, if they have an injury, 9 times out of 10, it'll go through a growth plate or it'll go through a different structure of the shoulder. I have not seen very many rotator cuff tears in young children. When we do see rotator cuff tears in children, the treatment plan is typically the same. We try to treat these without surgery, and if not, we move ahead to surgery. But I'll tell you, I can count on one hand the number of people that I've taken care of with rotator cuff tears that are younger than 18. Most of those folks will have injuries, let's say to the shoulder labrum or other structures. So it's less likely to occur in children. Please tell me some things we can do to prevent this from happening in the future. So one way to prevent injuries from occurring is to provide some degree of maintenance. So over time, depending upon what our levels of activity are, if we're not very active, the muscles can atrophy, they can become weaker, the muscle attachments become weaker. For instance, if we do weight-bearing activities, our bones actually get a little stronger. They respond to the forces that we place through them. The same idea holds with muscles and tendons. If we work those muscles and tendons over a period of time by doing regular exercise or by remaining very active with weight-bearing activities, we can strengthen the connections between the tendon and the bone, or at least we can prevent them from deteriorating too quickly. So I would recommend routine weight-bearing exercise to maintain the health of your shoulders. Sometimes folks will have injuries to their shoulders or to the rotator cuffs, and there's not too much you can do to prevent those. Sometimes life just happens. The next question, can you tell on MRI if the tear is acute or degenerative? That's a great question. So actually, yes, you can. There is a time frame that we can visualize on the MRI whether the injury is acute or chronic. I'll give you an example. If a person has a full thickness tear and they never had problems with their shoulder, and we get an MRI in a relatively quick phase, let's say within the first 2, 4, 6 weeks, we'll see edema or swelling in the bone, in the tendon. That's very commonly what we'll see. Sometimes we'll actually see blood or bleeding in that area because the tendon is alive, the bone is alive, and when these structures become injured, they can bleed. So in the short term, it's very easy to see. Now, what about the intermediate term? What if it's been several months or maybe 6 months? Can we tell as easily then? Not quite as easily because the blood products and so forth, they've moved along. Sometimes the edema or the swelling in the bone or tendon, they've resolved as well. But when we get a little bit further out, if the tendon is torn, the muscle belly itself will begin to atrophy. If you remember in the last question that I answered, I mentioned about how we keep our muscles and our tendons healthy by using them and doing weight-bearing activities. When we work a muscle, it gets hypertrophied or larger and it remains toned. If the tendon is cut and we can't work the muscle any longer, the muscle itself will atrophy, it'll get smaller. That atrophy typically is irreversible. So if we get an MRI of someone, their shoulder, and we see that the muscle belly itself is diminished in size, that tells us that the rotator cuff tear is more likely chronic or something that's occurred over an extended period of time. The next question, can you explain calcification and how that comes about? Well, calcification in the shoulder is usually called calcific tendinitis, and that occurs more commonly in women than it does in men. And that's when you typically have a small injury to the rotator cuff in the tendon itself, and the body, in its attempt to heal the tendon, will put calcium in that area. It's not really very effective in the sense of being able to connect the tendinous parts back together again. However, it does basically fill the gap that would have been created by the injury. That calcium typically is not painful. People live with it and it's not an issue. But occasionally it can cause pain. It can cause irritation. Sometimes we'll do what's called barbotage, which means we go in and we evacuate. We suck out that calcium with a needle. But then sometimes it leaves a void, which needs to be repaired surgically. Sometimes we could treat these conditions, even rotator cuff tears, with things like PRP or platelet-rich plasma, which helps the body's own mechanisms of healing and regeneration to take effect. Alternatively, if those things don't work, we can go and do a surgery to repair that area and clean the calcium out. What are the simple routine exercises to keep the joint flexible? That's a good question too. Well, forward elevation, bringing the arm up to the front, all the way up to the front, and leaning against the wall to really get maximum elevation, doing the same from the side, and then reaching up behind your back. One thing I see sometimes in folks that have shoulder problems is if they find that it's painful to reach all the way up or out to the side, of course, they can modify their activities, as I mentioned. But unfortunately, sometimes when they do so, the shoulder actually gets stiffer. That's where the therapy comes in and stretching. So a good stretching protocol will work on all ranges of motion: forward elevation, abduction, extension or reaching behind, internal rotation, reaching up the back, and external rotation, reaching out to the side. So those things can be worked on to maintain and improve upon the range of motion of the shoulder. Another question, can these surgeries be done as outpatient, or do I need to go to a hospital? I'm concerned about the complexity of the procedure as an outpatient. Can you provide guidance? Thank you. That's a great question. I will say the majority of shoulder procedures are done outpatient. They can be very complex. If you've ever seen someone build a ship in a bottle, you can see that it requires a lot of skill. There's a steep learning curve. But if you've been doing shoulder surgery with an arthroscope for a number of years and you are skilled at doing so, repairing these structures through an arthroscope is actually pretty straightforward. It can be done very safely in an outpatient setting, and patients are very, very satisfied with high success rates. So in my practice, I can do outpatient procedures, including rotator cuff repairs, labral repairs, treatment for impingement syndrome, and so on. And in fact, replacing shoulders in the same day. A shoulder replacement, you may be surprised to hear, actually is about an hour-long procedure, and the person typically goes home the same day. And it's done very, very safely, and many times without the use of narcotic analgesics. How do you treat osteoarthritis of the shoulder? Osteoarthritis of the shoulder is the wear and tear of the shoulder that occurs typically over time with use and so forth. There can be a genetic component as well. When the shoulder wears out and the cartilage wears down and you become bone on bone, and you've tried all methods of care, as I've outlined, with activity modification and therapy and injections and medications, we typically will treat that osteoarthritis with a shoulder replacement. Now, if the person is 55 or 60, a shoulder replacement makes a lot of sense. But sometimes I have folks come in that are in their 30s or 40s and their shoulder's worn out. What we try to do in that case is preserve the shoulder for as long as possible, because the shoulder replacement typically will work for the remainder of someone's life if they're in their 50s and 60s. But in younger folks, assuming they may have a longer lifespan, it may not last quite as long. So we try to maintain the original parts by doing various other procedures to preserve, maintain, and perhaps even restore some of the cartilage. Next question. If you get a reverse replacement, how much strength will return and in approximately how long? Great question. So a reverse shoulder replacement is a little bit different from what I've described in terms of the ball and the socket. Normally, our shoulders are made with a ball and a socket, as I showed you in the photos. But in a reverse, when we replace the shoulder, we put the ball where the socket is and the socket where the ball is. We typically do this for people that have irreparable, massive rotator cuff tears, and it works beautifully. So how much strength will return? Well, you won't be 100%, but I typically find in my practice, folks get to about 75 or 80% of their pre-injury strength. How long does that take? Typically, people after a reverse shoulder replacement are immobilized for 2 weeks. They go through therapy for 2 or 3 months, and then they're through. They're through with doing formal therapy. Their shoulder at that point will typically be at near full strength in terms of the 75 or 80% that I estimated. However, the shoulder will typically continue to improve in its strength for up to 1 year following the surgery. And that's why I follow folks for typically 1 year following that kind of a surgery, just to maintain or monitor their progress. Are tremors possible after the rotator cuff has healed down the line? Tremors are not typically associated with rotator cuff injuries or rotator cuff repairs. If a person has a tremor, we usually look for another cause for that. It can be neurologic, such as a nerve issue, or it could be more of a central issue in the spinal cord or up into the brain. That's something we typically try to evaluate further with a medical evaluation, but not very common in folks that have rotator cuff tears. What office locations do you go to? Well, I pretty much go to every one of our office locations. We have office locations in Pennsylvania in Langhorne at St. Mary Medical Center. We have in New Jersey, in Lawrenceville, Hamilton, Freehold, and Princeton. I happen to be in our Freehold office right now. So I attend all of those different locations. There's another office that we have in Marlton that I do not go to. Dr. Zach attends that office down there. He's our podiatrist. We don't have orthopedic coverage down there at this point in time, unless there's a need that may develop. Well, that looks like all of our questions. I really appreciate everyone's time. I thank you very much for your attention. If there's anything that I can do to ever help out with a shoulder issue or any upper extremity issue, please feel free to contact me. You can schedule an appointment, as you can see here, either online at our website or by calling the toll-free number. And if you have any questions regarding this program, you can certainly feel free to email us at the email address provided on this slide. And remember, the entire presentation will be preserved and uploaded to YouTube at our YouTube channel. Again, thank you very much. Stay well and be healthy.